Okay. Well, I appreciate people attending this really quite hopeless topic. This is an area that I, in the latter part of my practice life, have devoted the vast majority of my clinical and teaching time to, which is basically substance use disorder. And what I've learned in the course of doing this over the past 5 years or so, uh, focusing on this over the past 5 years or so, is the enormous influence that social determinants of health have on substance use disorder, on acquiring substance use disorder, and on being able to recover from it once it has occurred. And by the way, some of you may be aware that there's some discussion about even the term social determinants of health being a little bit too determinative or too definitive, and that it locks people into boxes that maybe they or we are not able to get out of because of using the term determinants. It makes it sound a little bit like a foregone conclusion, and it really isn't. I mean, those of us in clinical medicine and anything related to medical activities recognize every day that we see patients, we see clients, people who have had an amazing capacity to get beyond, recover from, pick a verb, some pretty drastic barriers to having good lives, and yet they have succeeded. And so I don't want the determinant thing to sound too definitive, but I have to say that in the course of my work, I have to be intentionally optimistic, because I deal with so many people every day whose lives are so turned upside down by substance use disorder and by adverse social circumstances that sometimes it's hard for me to even see a way out. And so I don't want this to be a downer of a talk, but it is. There are a lot of pieces to this, and I think that as we get into it, we will see that while there are things that all of us can do at our local level to help make things better, a lot of this is systems and political and state, and at the state and federal level, not just the community level, where the solutions are going to be found. So I don't have any disclaimers other than to say that I was late to getting into substance use disorder care. I'm a family doctor here in Pocatello. I work with Health West Community Health Center and with Idaho State University Family Medicine Residency. And I think like a lot of clinicians, I've been really busy. And also, like I think a lot of clinicians, I had a certain amount of bias and prejudice towards the substance use community. And it went something like this. Well, they made choices, and so if they want to stop using, they can stop using. And that position I hear stated sometimes by some of my own colleagues, and it's very misinformed position to take on this subject, which is very complicated. It's very nuanced, but I think that healthcare providers, individually and collectively, we need to look at our own implicit and explicit biases and recognize that we sometimes are not always part of the solution that we need to be. The goals and objectives here are to understand the bidirectional nature of adverse social determinants of health and substance use disorders. And what that means is, and I see this play out every day in my clinical practice, where poverty and lack of education, lack of a good job, impaired relationships, frayed connections with individuals and with the community contribute to substance use disorder. And then once a person starts using substances, then that further, it turns back and it makes the situation worse, where employment, housing, um, economic stability, relationships, and so forth become even more uh, fraught than they were before. So this is definitely a bi-directional thing. I chose the graphic on this particular slide because that's what I think individuals with substance use disorder and accumulation of adverse social determinants of health feel like. They feel like they're kind of stuck there, and there's all these forces around them over which they have either no or very, very little control, and it's so hopeless that it keeps people in the same rut that they're in. We'll talk a little bit about the impact of social determinants uh, and substance use disorder in rural areas, which is where we are here in Southeast Idaho. And we'll focus on some case histories, which I think illustrate the point. So to kind of get the ball rolling, let's talk about case number one. This was a 35-year-old female who I started seeing about 3 years ago, had an extensive history of ACEs, early childhood neglect, physical and sexual abuse. Started using various drugs in mid-teens. At the time that she was starting to see me, was working at a minimum wage job, was struggling to make ends meet, had a domestic male partner who also was using drugs consistently, mostly methamphetamine and opiates at this point. She had lost, with the advent of the fentanyl epidemic in this area of Southeast Idaho about 3 years ago, she had lost a number of friends to accidental overdose and decided that she had better get some help before that happened to her. She would engage a little bit in counseling and then would drop out, and would engage in counseling, drop out. The big thing that she was doing, and she and I discussed this on a number of occasions, how well Suboxone, which is buprenorphine naloxone, how well that medication managed her cravings and kept her from having any withdrawal, and yet she would periodically stop Suboxone so that she could get high. And we had a number of discussions about that. My trying to impart to her how dangerous that was, and then lo and behold, not a very short time after my last visit with her, she died from an accidental overdose. And so this is an example of what we really want to prevent. I talk to my patients all the time, and I tell them that I've got my hierarchy of things that I think are important, and number one is keeping them alive. Number two is keeping them out of jail and prison, and then the rest of it can kind of fall into place after that. Oops. So case number two is a gentleman who I started seeing about 5 years ago, and he had an interesting story. When he was 9 and 10 and 11 years old, as was his recollection, his mother would give him her own methadone in order to keep him calm. She was on methadone for in a pain management type situation. In his early teens, he started using alcohol and the other drugs that are so readily available. Did not graduate from high school, later was able to obtain his GED. And my recollection is that he did get his GED while he was locked up, mostly incarcerated during his 20s and 30s. And if you think about people who are either using drugs or they are incarcerated during some really important formative years of their early adulthood, in my own simplistic way, I think of this as sort of putting a pause on their growth and development. Certainly the regular drug use, I think, does that. It sort of keeps people who start using in their teens, it sort of keeps them stuck in that stage of well, if you will, prefrontal executive functioning development. And the same thing with prisons and jails, where because it's not a reflection of the real world. It's a very structured environment. It's not, and not that it's pleasant, but it's certainly structured. And people simply are not able to learn the skill sets that they need to not only survive but thrive out in the real world. Nevertheless, he comes to me. Started seeing him in 2018. At the time, he was homeless and unemployed. He had a female partner who was regularly using meth. He had, like a lot of folks who have substance use disorder, had major depressive disorder, PTSD, and panic disorder. Uh, Long story short, the first 2, 3 years that I saw him, first 2 years anyway, he was pretty good about staying off opiates, but was continuing to use meth. We kept him engaged in the program. I like and I'm not an addiction expert, but the addiction experts recommend keeping people engaged rather than quote unquote firing them for continued use. And that the idea is that you will have a better chance of getting someone to the recovery line if you stay with them rather than telling them to not come back because they've got bad urines. So scroll forward 5 years. Now he's been clean and sober for 3 years. He's got a job that he really likes. His girlfriend got into a treatment program. She's been also quote unquote clean and sober for the past couple of years, and they are doing wonderfully well. And I see him now about every 2 to 3 months, and it's always so gratifying to see him. And he's so proud of how well he has done and how far he has come. And if you look at where he came from the poverty, from the lack of education, from the bad family dynamics, from the drug use in early childhood, and so on and so forth, where he is right now is virtually miraculous. And I have to focus sometimes on stories like that to help me kind of get beyond patient number one, who unfortunately happens all too often as well. Case number 3 is a transgender male, assigned female at birth. And again, this is another one of those social determinants of health in terms of prejudice and stigma towards a certain population. Transgender people in our culture in general, have a rough way to go. This trans man would have a difficult time potentially anyway, but he also has pretty severe bipolar 1 disorder, and PTSD and a constellation of other issues going on. And it has been very, very difficult for him to maintain decent mental health and housing at the same time that he is also using drugs. And what happens with him is he will come off his bipolar medication. He will have a manic episode. He will start using more drugs during that time. Also have indiscriminate sex with men he really doesn't even know. And I have tried over the past couple of years to keep him on pre-exposure prophylaxis for HIV prevention because I'm so fearful, more so than he is, I think, that he's going to acquire HIV during one of his episodes of mania when he's having indiscriminate sex. His last appointment with me was actually a few months ago. I don't know where he is right now. I have not been able to get in touch with him. And so this is an example of what can happen with somebody where between the mental health disorders and the social issues and including the substance use disorder, all add up to a situation that I'm afraid is not going to end well. So first, just a little bit about opioid use disorder. Many of us know that the deaths now from opioids exceed 100,000 Americans a year. And when we think about that, that's a huge number, and that's horrible, and that's what has gotten everybody's attention. In fact, that's why opioid use disorder has taken so much of the attention away from methamphetamine use disorder. Both of these conditions um, can and cumulative and together they're more likely to lead to a fatal overdose. But even individually, and even if you don't die, the impact of opioids and methamphetamines on individuals and families and communities is just absolutely enormous. Um, I mean, I see this played out all the time where people wind up in the emergency department either with an overdose or with something really serious like a heart valve infection or a spinal bone infection from drug use, resulting in very, very expensive hospitalizations. Uh, so the cost for individuals and communities and taxpayers is absolutely enormous. So 2.6 million Americans have opioid use disorder. The number of deaths in Idaho relative to a lot of other countries seems quite small, but is still significant. And the latest numbers that we have is 2021 because COVID has kind of thrown a monkey wrench into some of the data collection over the past couple of years. You see the ER visits there. And then it's worth mentioning how many or the proportion of the prison population that either has an active substance use disorder or were incarcerated for a crime involving drugs or illicit drug use. And it's no secret either that the jail and prison system in our country is the primary treatment center for people with substance use disorder because of the way that our laws are structured and the way that we have historically dealt with people who not only sell drugs and traffic in drugs, but also just simply use drugs. And so this kind of, if you can hear my bias coming through a little bit, here's where one of the things where we as individuals and as taxpayers and as citizens need to work on coming up with better strategies for managing substance use disorder besides incarceration. Only 1 in 5 individuals in the U.S. with opioid use disorder are receiving medication, and the evidence is very, very clear that medication like Suboxone plus counseling is the best treatment for opioid use disorder. There's a lot of reasons why the proportion of people who have opioid use disorder getting effective treatment is so low. Some of that is because many folks who are in the middle of their addiction simply don't know about Suboxone. Others don't have a sense of optimism that it can work. I'm seeing a patient now. I've been seeing him for about 5 years, who, when he first came to me, he had been holed up in his house for about 4 years, had not been working. His wife brought him in. She said, "I'm sick of this. It's either you get some help or I'm out of here." So he comes in, his wife comes in with him. He was pleasantly defensive, um, i.e., he seemed to be a nice guy who just didn't have any sense that he could ever get better. So we started him on Suboxone and started seeing him regularly. And within a month, he had gotten a job and did really, really well. for about the first 3 years. And then there was a family situation that caused him to relapse. And he went back to using for about 6 months. Fortunately, did not die, did not wind up in the hospital, and then came back again, and now has been doing really well for the past couple of years. And he is a good example of how helpful Suboxone and medications like it can be, but also it indicates how that's not the complete answer, because even when a person gets on medication and gets the withdrawal symptoms taken care of and gets the cravings under control, all of life's issues are still going on. And in fact, I've even had a few patients tell me that when they got quote unquote clean, they felt as if their mental health issues became destabilized because all of the stuff that they had been dealing with for years through self-medication, they'd kept all these things kind of tamped down through using substances. And now that they're no longer using substances, all those things come bubbling to the surface. And this is where the counseling piece of this is so important, to help people navigate all that and learn how to get through it. So I am a huge proponent of medications for substance use disorder, or for opioid use disorder, but I am the first to acknowledge that it's not the only solution. By the way, there have been studies done that show when they compare counseling alone versus medication, or medication plus counseling, for opioid use disorder, the medication and medication plus counseling is dramatically more effective than counseling alone. So for people who think that counseling is sufficient for most patients with opioid use disorder, they are simply not correct. Most people are going to need medication, which is not to say that some people can't do it cold turkey and do okay, and some people can't do it with counseling and do okay. But the data indicates that if you look at populations, that people are just better off using medication. The factors contributing, I am an old guy. I've been around for a long time, and was practicing in the 80s and 90s and the early aughts. And this is when physicians were being told by our specialty organizations and not coincidentally by Purdue Pharma, the maker of OxyContin, that we were under treating pain and that we needed to be more aggressive in treating pain. Pain is the fifth vital sign. I can remember when that little lingo came out. And so we collectively sort of bought it hook, line, and sinker. And the upshot of it is that we overprescribed opiates. And then we started getting into, within a few years, recognized that we were contributing to the problem. Drug company marketing is an issue, the illegal drug supply. I'll show you a slide in a second about a recent headline addressing drug bust. ACEs, which all of you know about, adverse social determinants of health, which we're going to talk about. There's seems to be a genetic connection here too. I talk to patients regularly, and I will ask them, for example, so when you took that first dose of hydrocodone after your wisdom tooth extraction, or how long after you started taking the hydrocodone for your dental work did you realize that you liked how that medication made you feel? Some of those folks will say, I could tell after the first dose, I liked it. I just liked it. And the upshot of that is that it causes a euphoria effect in some people. And that is a setup for trouble, because if a drug stimulates that portion or that pleasure center in your brain, and it gets repeatedly stimulated, pretty soon, other things that would ordinarily tweak on that pleasure center, like a good meal or a beautiful sunset or good sex or the other things that we tend to think of as being pleasurable, pale by comparison, and then you're off to the races. Mental health disorders, huge connection between mental health issues and substance use disorder. And again, bidirectional. People who have mental health disorders are more likely to use substances. People who use substances are more likely to have mental health disorders. So methamphetamine, if you look at sheer numbers of people who are using drugs in Idaho, for example, meth is still number one. Opiates are killing more people, but meth, more people are using meth. 4 out of 5 people who use drugs in rural areas reported using meth in the past 30 days, which is just incredible. And then I threw in this other line, this last line here, because it uses the expression that we've all heard, deaths of despair, with drug overdose, suicide, and disease linked to drug and alcohol use. And this is kind of ties back into the social determinants again. So for those of you who don't know, this is a little baggie with crystal meth. This is that headline that I was mentioning. This came out in Idaho reports. This is from the U.S. Attorney's Office, District of Idaho, in August of 2022. And here's the thing. The supply of meth and now fentanyl is really dependent on the demand. And as long as there's a demand, there will be a supply. There are people who will simply find a way to produce and distribute drugs as long as there is a demand for them. And so part of what we have to think about as healthcare providers and as a society is, what are the things that we can do to try to reduce the demand? And that's part of where this whole social determinants things comes in. And as you will see as I get farther into this, I don't have good solutions. And this is why this is such a huge, huge issue. And I think it's why we have such a hard time coming up with lasting solutions, because it is multifaceted and it's just simply enormous. This is to give you an idea of the counterfeiting that's going on. The top pills are, well, I'll have to read the headline just so that I can know. One of these is is the real one, the real oxycodone, and the other one is I think this is the real one here, and the other one is the phony oxycodone, which is fentanyl, aka dirty 30s. And dirty 30s, i.e. counterfeit oxycodone, which is really fentanyl, is basically the opiate of choice now pretty much across the country and in Idaho. For one thing, it's a lot cheaper than heroin. It's a lot cheaper than buying the real things. And fentanyl is about 50 times more potent than heroin. And so you can kind of get an idea of why we're in the kind of the mess that we're in. The other thing about this substance here is that because it's manufactured, and the thinking is that the raw ingredients are basically produced mostly in China, shipped to Mexico, made into pills, and then they get on essentially for us the I-15 corridor and get shipped up to us. The way that these dirty 30s are being manufactured, there's not any quality control, obviously. If I'm going to be prescribed a 30 milligram oxycodone or Oxycontin tablet by a physician, and I get it from a pharmacy, I can be pretty sure that there's going to be 30 milligrams of oxycodone in that tablet, and in every tablet in that bottle. Whereas with the illegal stuff, the amount of fentanyl in each dirty 30 in each tablet is wildly variable, ranging from a lot to a little. And this is why back in the old days, people could smoke heroin, for example, and nod off before they would be at risk of having a fatal overdose. Now in the Dirty 30 era, and these pills are the ground up and smoked, you can have a fatal overdose from basically one hit off one Dirty 30, one illicit fentanyl tablet. So it's just incredible how potent this stuff is. The second set of pictures here just shows the counterfeit Adderall. The top one is the real Adderall. The bottom one is the Adderall mixed with meth. And then the third picture shows counterfeit Xanax tablets or alprazolam, which is a very popular benzodiazepine on the streets because it's short acting. And I mean, it works really quickly. So the white one is the authentic one, and the more yellow one has a fentanyl in it. So the drug supply now in Idaho and in this country has been so contaminated with counterfeit stuff that nobody knows what they're getting. I saw a patient yesterday who I've been seeing for a while, a woman who has a number of barriers to recovery, and she had opiates in her urine, and I asked her about that, and she said, well, I'm never going to do that again. She said, I was feeling really badly. There had been a recent death in her family, and she has not worked her way through that yet. And she said, I just felt like I needed some relief, and a friend called, and they said they had some stuff, and could they come over? And so they did, and we smoked. And she said, whatever that was, it was not heroin. It was not anything that I was ever used to before. She said, it just knocked me on my butt. Well, this is how people die accidentally from overdoses. And it's also, she reflects what happens with people who, she's been using substances off and on for 20 years. She has a number of mental health issues. And it shows how the lack of resilience, I guess would be the word. People who, most of us have to learn in life that there's going to be rough patches, and we have the wherewithal to get past them. If you use substances, then that substance becomes your go-to place, your go-to thing to feel better. And it's really hard for these individuals to get beyond using that go-to place to feel better. And so that's a lot of the discussions that I have with my patients is how to come up with another option instead of using. This is scary here. This is just a picture showing brightly colored fentanyl that is, again, stamped to look like oxycodone. And teenagers and young people are dying from this stuff. So what are social determinants? Well, we all know it's where we live and work and play and worship and so forth, go to school. And substance use disorder, the briefest definition that I could find is just simply excessive and harmful use of drugs and alcohol, typically. Now, there's other substances too, including tobacco, which is a major problem. But in terms of life, well, in terms of this discussion, we're focused mostly on methamphetamine and opiates. So we've all seen the pictures of this intersection with all these social determinants. I just pulled a few of these offline just to show the picture of how they're all kind of intertwined. This one here I like. The pessimist in me likes this one because this picture reminds me of a knot, of a kind of a rope or something that's just kind of tightening around that individual in the middle, who's trying to control these elements, and yet it just gets tighter and tighter. And I think that sometimes is what our patients feel like, our clients feel like. That second statement there that I bolded, clinical care impacts only 20% of variation in health outcomes, while social determinants affect as much as 50%. even before I started doing substance use disorder work, and I was doing broad spectrum family medicine, which was taking care of a lot of folks with high blood pressure and diabetes and COPD and all the usual stuff. It's been so clear to me over the years, as it is to many people, how social determinants negatively impact all of those conditions. I mean, my goodness, the diabetes is a perfect example of a patient who develops diabetes in part because of the social determinants, because of poverty, not being able to afford to eat right, not even really in some circumstances not knowing what eating right is, but even if you knew, you wouldn't be able to afford it. Not getting enough exercise, not having enough education, working at a low end job, or sometimes even more impactful, having health conditions or mental health conditions that keep a person from working at all. Then they get on the disabled rolls, and so often that just sets up a vicious cycle of people, of just, again, just kind of leading into more and more issues. But so the social determinants affect a lot of things, and not only um, issues pertaining to substance use. In fact, the data is very clear that all of these health outcomes are impacted by social determinants. And I just illuminated substance use disorder down there, but every one of these gets tied in together. And if you look at substance use disorder as a single thing, and then you look at it with all of the other things as well, substance use disorder it ties in adversely with all of these other things. It contributes to more mental illness. It can contribute to cancer, disability, chronic illness, can contribute to hypertension, diabetes, heart disease, infant mortality. I mean, it is absolutely a pervasive issue when it occurs. So this is another pictorial image of social determinants. I took this from Healthy People 2030, and I like the simplicity of it. And I would encourage anybody who wants to dig more into the weeds on this to go to just Google these Healthy People 2030 and kind of dig around in that. It's a fascinating walk into these social determinants. It's hard to talk about social determinants without talking about poverty, and this slide to me is amazing. This is the share of total U.S. wealth by percentile group in the United States in the first quarter of 2022, and the top 10% in terms of wealthy people, the top 10% of the wealth, the top 10% control nearly 70% of the wealth in the country. The bottom 50% have only just under 3% of the wealth. This is an enormous wealth gap. And in my opinion, contributes to a lot of the issues that we are talking about this morning. You may have been hearing about the UAW strike and this guy, Sean Fain, who is the new leader of the union, how he's speaking out against billionaires and how it's not really right or ethical or moral that we have billionaires in this country while we have people who don't have enough to eat. And this is not Neil Ragan putting forth an argument for, well, we should take on a communist or a socialist role, but it is Neil Ragan saying we need to look at how we structure our tax system and so forth in this country to where we can help people in the lower 50% and maybe not give quite so much support to the top 10% who don't need it. There are now, by the way, in the United States, 750 billionaires, just little bit of trivia in case you wanted to know, and presumably none of you on this call are in that category. I'm certainly not. So one of the first social determinants, and we mentioned poverty briefly, housing instability, food insecurity, and employment. And I see folks every day in my practice who struggle with all of these things. And if you think about it, if you think about what if you don't have a place to live? What if you're homeless? Even if you have a car and you're living in your car, so you've got transportation, so, ostensibly, if you can afford the gas and if your car is working. But if you don't have a place that you can keep your clothes, keep your stuff, take a shower, how are you going to get a job? I mean, it's where do you start? And so this is why some cities, some of the more progressive cities in the country now are looking at a thing called housing first, which is getting people housed and then helping with the other things. But it's very hard to address employment, food insecurity, and other issues if you don't have housing. Fortunately, I don't have all that many homeless patients. I've got a very, very small handful. I do have a lot of patients whose housing situation is not very secure. They're just barely getting by. The education access, this the early childhood development education is huge, and this is one of those things, and I can't remember that expression, but it has to do with a butterfly flaps its wings in North America, and a storm gets created in South America. Uh, at my clinic where I work, we keep a supply of children's books, and when we have kids come in, little kids, typically preschool and barely into school, we will give the children a book that they can just have to take with them. This is our little way of trying to stimulate that child to read and stimulate maybe the parent to read to the child. And little things like this can make a huge difference in a kid in terms of their later life. A child who grows up knowing how to read and enjoying reading, studies have shown that these kids have a huge leg up on the kid who was never around any books at home and doesn't like reading. High school graduation, obviously important. Plenty of studies show that people who don't graduate from high school have a lot of barriers to getting decent jobs. Enrollment in higher education. This refers not only to four-year colleges, but it also refers to two-year colleges and refers to trade schools and other types of education. For example, if you've tried to hire a plumber or an electrician lately, you know how in short supply they are. We need plumbers, we need electricians, we need mechanics, we need all kinds of people to do for these very important jobs. And we need to get more of our young people and even older people, for that matter, who aren't interested in a college education to get geared into these other fields. Language and literacy, hugely important. I have a few patients who have so much trouble with reading and comprehending that I have to be careful when I prescribe medication to them that they understand how to take the medication. This is a huge barrier to a good life, really. The access to health services. People will say, well, this is America, and so anybody can go to the ER and get their health care. That's true to a point. I mean, if you don't have health care, if you're not seeing a physician, if you don't have any money, and you're having chest pain that you think could be a heart attack, and you go to the emergency department, They will be very happy to see you, and they will be very happy to treat you. If you are having a heart attack, you'll get taken into the cath lab, you'll get your stents, you'll get all this stuff. But what's missing from that equation is what happened before that and what happens after that. What happened before that is you probably had high blood pressure that wasn't being managed very well. You may have had diabetes that wasn't being managed. You may have had a whole number of things that contributed to the heart attack that were not being addressed because you didn't have the money for access to healthcare. And then after the heart attack, if you don't have a primary care doctor or somebody who can help you to make sure that you're on the right medications and doing the right things, then you're going to wind up getting in trouble again. So the access to primary care is so critical for maintaining health. And there are a lot of people in this country who still do not have good access to primary care. Health literacy refers to it's different literacy than general literacy. It's defined by the U.S. Department of Health and Human Services as the degree to which individuals and organizations find, understand, and use health-related information and services. And so I spend a fair amount of my workday helping people navigate the health care field and to figure out how to get things done, how to get the care that they need. Neighborhood and built environment. If you're living in a location where there are gangs and where there's poverty and crime all around you, that is going to have an impact on your ability to stay healthy. There's just not any question about that. And so all of us as citizens have got to work on how we can improve our communities. And I'm not talking about improving our gated communities and improving our communities that have the beautiful lawns and that have gardeners and that kind of stuff. I'm talking about all of our communities. And that includes the quality of housing. And this gets to, the lead issue back in Flint, Michigan, in the water pipes. There's all kinds of things that we as a society need to be doing to try to help to lift up those in our community who are less well off than we are. The civic participation, discrimination, incarceration, social cohesion. I take care of a lot of folks who have been incarcerated, and it's always amazing to me how, and not in a good way, how difficult it is for these folks after they are released from incarceration. Sorry. I have patients who will say, I'll be asking them if they've been able to get a job yet. And this is sometimes weeks and months after they have been released. And sometimes the answer is, well, yeah, I went to this place and I interviewed and they really liked me and they thought I'd be perfect for the job. But I'm on felony probation. And so they said, come back in 5 years. And they would be happy to hire me in 5 years. That's a problem. Problem getting decent housing, problem getting a job, all kinds of issues confront folks who are being released from incarceration. And this, again, is another one of these societal issues where we talk about wanting to, we recognize that people who are incarcerated are not going to, the vast majority of those folks are not going to stay incarcerated. They're going to be coming back out into our communities. And we give lip service to the notion of wanting them to succeed, and then we end up throwing up barriers that ensure that or that contribute to the fact that they are not able to succeed. And I'm about out of time, so there's way too little time to discuss discrimination as it pertains to race and gender identity and sexual orientation and all these other things. But these are, again, huge issues. One of the things that we know about substance use disorder is that it tends to be a disorder of disconnection from the community, disconnection from families. And the social cohesion part of this is so important in the context of recovery from substance use disorder. And that brings me to my last slide, which is solutions. And interestingly, we're out of time, and that's probably just as well, because I don't have any solutions. This talk was more to lay out the fact that substance use disorder and social determinants are intimately connected. It's a hugely complicated subject, a hugely complicated problem, and it's not going to get fixed by simple solutions. So thank you all for your time. I really appreciate it. And I've got time for questions if anybody has any. And thanks again. I appreciate it.